Okay, let's get started. So welcome everyone. Thank you for being here. Just 30 seconds of housekeeping, even less. I ask that you keep yourselves on mute during the program. And if you have questions, please submit them in the chat. And then at the end, I will read the questions for our panelists. So without further ado, I'd like to introduce Stacey Feldman, Director of Impact of Federation, for a brief word about Federation.
Dan, you're already stealing lines from my
I know.
opening remarks. You're killing me, and we've barely begun. Good evening, everyone. So like Dan said, my name is Stacey Feldman, and I'm the Director of Community Impact at the Jewish Federation in the heart of New Jersey. And I oversee all the impact that the agency makes and has with the agencies that we support and the organizations we support in the community. And it is truly my privilege to welcome you and open up this much needed conversation around mental health. So there could be some of you who are only here because of the toll that the coronavirus has taken. And while it has certainly upended the world in ways we never could have imagined, let's get real. Mental health issues existed well before COVID-19, and they will be around well after COVID-19 becomes just another vaccination that we take annually or once every couple of years, just like the flu. So according to the National Institute of Mental Health, 1 in 5 adults live with some sort of mental health issue. So when I look around this Zoom room, that's roughly 4 to 5 people on this call who are having some sort of mental health challenge. And that's if you're able to admit it, because many people don't. And that's what tonight's all about. It's about ending the stigma around mental health. So you'll hear about how to have an honest conversation with yourself, your friends, and your family, and to be able to comfortably say, hey, you need help, and that is okay, because let's face it, everyone needs a little bit of help sometimes. You'll also learn about available resources in our community. And as an agency who directly supports organizations and groups and people who help vulnerable populations, and mental health is included in that, Jewish Federation knows that there are dozens and dozens, if not hundreds of places for community members to seek support. But if you don't know where to go, you don't know where to go. So we'll tackle that a little bit tonight as well. So again, thank you for being here. It's already a step closer to whether you're helping yourself or someone else or someone you might not even know yet. It's incredible. And without your support, Federation would be unable to work with the valuable partners that we've got on this panel tonight and bring programs like this to the community. So now I'm gonna let our panelists and our speakers go on with our program. So thank you.
Thanks, Stacey. So I would like to have each member of the panel introduce themselves briefly before we get to the actual discussion. Dr. Israel, I'd like to start with you. That's okay?
Sure. I'm Jessie Israel. I am the Senior Vice President of Geriatrics and Palliative Care for RWJ Barnabas Health here in New Jersey. I am a practicing geriatrician and palliative care physician, and happy to be with you all tonight.
Thank you. I'm just going to go in order of how I see you guys on my screen. So Bill?
Hi, my name is Bill Stover. I'm the Associate Executive Director and Clinical Director for Jewish Family Services of Middlesex County. I'm a licensed clinical social worker and have been practicing in working with adolescents, adults, and every other kind of person for the last 40 years or so.
Marc?
Hi, I'm Rabbi Marc Kline in Monmouth Reformed Temple. I am the Interfaith Chair for the Jewish Federation, Heart of New Jersey. I serve as police chaplain in Red Bank and hospital chaplain for the Hackensack Meridian system. Blessed to be here, and thank you everybody for participating.
And last but not least, Joe.
Hi, my name is Joe Gratzel. I am wearing a couple of hats tonight. I am the family, my family are consumers of mental health services. And so I have the perspective of a dad accessing services for my kids. I'm a pastor at the First Baptist Church in Manasquan, New Jersey. and involved in community responses to tragic loss and disasters, and how we build community response. And I'm also an educator. I do mental health first aid training for first responders in Monmouth and Ocean County. And I just want to take a liberty, and I think the other panelists would be okay with this, and say these conversations that we're going to have tonight can be really close to home. And if you get upset by the conversation tonight and you need to talk to somebody tonight, right away, if you let Dan know, somebody on this panel will go offline and call you on the phone and make sure that you're safe and that you have resources. So if this conversation gets too close to home for you, please let Dan know through the chat, and someone on this panel will call you, and just be sure that you're okay and that you have some numbers or whatever you might need to be safe tonight. So I hope you don't mind me taking that liberty, but these can be difficult conversations for us to have.
I really appreciate you saying that. Thank you. Okay, so I will be asking a set of questions to each of the panelists, and each of them brings their own expertise, and they will talk to that. And then, like I said at the end, if there are questions, we can read the questions and ask them. So, Marc, I'm going to start with you. So as a rabbi, I'm sure you are engaged with community members dealing with mental health issues all the time. So from your perspective, or from what you hear, what are the challenges that people with mental health issues face, and what are we as a society doing wrong in the day-to-day? And your reply will be a perfect segue to the questions I'll be asking Joe next, in regards to how we can respond as a society. But first, Marc.
Thanks, Dan. Let me first say that February is Jewish Disabilities Awareness Month, and that's why we're here. As a group, we decided that probably the most pressing need when we in the conversation of disabilities is to talk about mental health, because most people don't understand it as a health problem. That's why we're the name of this this program, to remove the stigma. And it's a very private disability. If you have something that's physical, it's evident to the people that you're with. But these are latent, and not only sometimes are we not willing to have the conversation with ourselves, but we're not able to even address it. We don't even know that it's there. So awareness is huge, both for how we see ourselves when we look in the mirror, but also how we can take care of each other in a much more effective and efficient way. So I would echo what you've heard in that mental health issues infect and impact people in large numbers, some in small ways, some in large, but so many of us, especially in times of trauma, end up suffering in ways we don't even realize.
Marc, I'm sorry to interrupt. We can barely hear you. Can you move a little bit closer? Or
is this better?
Yes, thank you.
Okay. So the reality is that mental health issues impact so many of us, some in large ways, some not, but they create even greater trauma when not addressed in meaningful ways. People who can't get jobs because they don't they don't have the ability to walk through an interview without anxiety, to be able to handle the tasks of a 40-hour work week or a 20-hour work week. Postpartum depression, something that we don't often think about, and certainly men don't think about, but is debilitating. So people come to us from all different ways of and walks of life, and there's no cookie cutter diagnosis and there's no cookie cutter approach. Someone comes with a broken leg, you can set it. We've even fixed cancer to the point that there are protocols for addressing the different types of cancer. But every case of mental illness presents in a very different, unique way, because it impacts everybody uniquely. So what we've done is gathered people here tonight to address the different, I guess, facets, age groups, and cultural pieces that go into greater awareness. with the hope that we can provide some skills in recognizing and addressing mental health concerns, and then providing tools and resources so that we can take better care of each other. And Joe and I both serve congregations where we counsel with people privately, never mind what we do in the larger sector. And there's a lot of hurt. And Stacey said, this is not just about the pandemic, but certainly the isolation that people are feeling right now is the triage that needs to be addressed. For whatever issues people are facing on a regular basis, this has only made it worse, as people who need society and need people don't have the resources that they used to be able to rely on. So thank you everyone for being here. And Dan, if you could get Joe's expertise started, I think we'll all benefit.
Sure, not a problem. Joe, I actually just thought of something. Since you're all about responding, would you prefer to be the last in line?
No, because I think that the unique perspective that Bill and Jess bring in terms of specific populations will dovetail well with where I'm going, I think.
Okay.
So I guess for me, we're going to hit my questions at this point or come back to them.
Yeah, so you're you're here to talk to us and help us understand how we can respond as individuals, as congregations, or faith communities, and also how we can reach out to the members of our community, I guess, to increase awareness, to bring them, to help them be more inclusive, is what I'm.
So
I think yeah.
Got it. So probably, and I can't see, there's 20 or so people I can't see on here, but if I asked folks to raise their hands and said, how many of you at some point along the way have taken a CPR course? My guess would be that a significant number of the folks that are on with us this evening have taken CPR. And CPR is what we do in an emergency to make sure that we keep somebody alive until the first responders, who are the medical people, arrive on scene and bring a defibrillator and get people, the appropriate medical help that we need. But we don't have that same triage mentality that Rabbi Marc mentioned to how we help people who are experiencing a mental health or substance use crisis. And so as individuals, you all have taken a first step by being with us here tonight, which is to learn a little bit more about mental illness and to learn that mental illness impacts people across the entire lifespan and impacts their ability to live, laugh, love, and learn. And so when we reduce stigma around mental illness, we can reduce barriers that prevent people from accessing the care that they need. Stacey mentioned at the beginning of the program, about 1 in 5 people in any given year will have a diagnosable mental illness. Lifetime, that number goes to 1 in 4, but only about 40% of people who have a diagnosable mental illness actually receive any treatment. And the delay from onset of symptoms to when people get treatment, the median delay is 10 years. And a lot of that is about barriers to care, and a lot of that is about costs of care, and stigma is a huge deal, and that's why we're here today. So 3 areas very quickly that I would encourage you is, 1, become an informed consumer. Learn more about mental health and about the services that are available in your community so that you can help the people that you know around you, your loved ones, your friends, your neighbors, your coworkers. And if there's a sentence I would love you to leave with at the end of today, it would be a sentence that's something like this: Dan, I've noticed, fill in the blank, and I'm concerned. Why don't we fill in the blank? Now that tells Dan 3 really important things. First of all, it tells him he's not fooling me. I've noticed that he's having a difficult time. The second thing it tells him is I'm not mad at him. I'm concerned for him. And the third thing it tells him, which is really important, is I said, why don't we? And that means that I'm going to be his ally. And that doesn't necessarily mean I'm going to solve his problems. It might mean, why don't we go out and have a cup of coffee? It might be, why don't we sit down and look through the directory of your insurance coverage and see where you can get help? It might be, why don't we call a hotline together and find out where services are available in our community? But if you could leave with that simple sentence, I've noticed, I'm concerned, why don't we? There are a couple of resources, and can I type into the chat, or can only you type in the chat, Dan?
I will give you, hold on one second.
Okay, so I'm going to just list off very quickly a couple of programs that you can look for in your community. One is called Talk Saves Lives. That's broadly out in the community. Another program is called More Than Sad. Those talk about suicidality and depression. Another is Psychological First Aid, which is a great course you can take online. And that really is more of a immediate aftermath of a trauma or a crisis. Another is QPR, and I forgot to write that one down for myself, which is a suicide prevention. You can also take online or in your community. And then I teach a course called Mental Health First Aid, which is an 8-hour training, which can be done virtually or in person. And it teaches you how to recognize and respond to someone who's experiencing a mental health problem or crisis, or a substance use problem or crisis. So first thing, as an individual, get a little bit more information so you know what's out there, and learn where the resources are in your community. And if you don't know where they are, you can go to nj211.org and you can find resources in New Jersey, or there are information and referral, I&R, information and referral services through most of the county offices. And my guess is that Jewish Family Services, Bill, do they do I&R? So you could call Jewish Family Services, and if they don't have that service, they do I&R, they do information and referral, and they'd be glad to tell you where to find them. So find out what services are available in your community. The second thing is that congregations can help by providing forums for this kind of education. I've trained folks from all walks of life and all faith backgrounds in congregational settings and in community settings, where we build bridges between our community by providing courses like QPR or Mental Health First Aid or More Than Sad, which there are agencies out in your community that will bring those to your organization in person when that's feasible, or virtually for low or no cost. So I'd encourage you as congregations to create an environment where education can happen around these topics. And then the third thing, just briefly, in terms of what we can do in our communities, most of our faith communities are perceived by people outside of our community as being very insular. People have the assumption that people in any one faith community only take care of the folks from their community. I will say, to be fair, in the Black church tradition, there's more of a community outreach than there is generally in white faith communities. But generally, faith communities are seen as being organizations that take care of their own. So when faith leaders in a community stand together and talk about these issues, it's powerful. It reduces stigma, it broadens the impact in terms of what the communities do together, and it makes it easier to do these kinds of educational programs that we talked about. So for example, when the opioid crisis became a big deal in our communities, the faith communities got together with the prevention community, and we hosted a series of forums, one of which brought 500 people to a local movie theater to talk about substance use and talk specifically about heroin. And that was a multi-faith effort to come together. And people saw the faith communities as a resource in ways they never had before. We are very rich in our faith communities. We have doctors and lawyers and nurses and psychologists and psychiatrists and teachers and clinicians. And we have all of these folks in our faith communities who would love to bring their skills to bear in the broader community if we could open the door for that to happen. So those are my three things. As an individual, get educated. As a congregation, create these spaces where people can learn. And as faith communities, broaden your reach to other faith communities and other people of goodwill, the Rotary Club and the Kiwanis Club and local organizations in your community who want to help, and see how you can build a bridge together. That's my spiel.
Thank you, Joe. And there have been requests, if you can list
Yes.
that I've enabled the chat for everyone, so you can go ahead and do that.
Thank you.
That was great, very informative. Dr. Israel or Jess, I'm gonna turn to you. I've a bit of a loaded question here for you, but if you need me to stop in the middle or read it over again, please let me know. So you mentioned that, you know, among other things, your expertise is in geriatric care. Can you speak to how depression presents differently in older adults, you know, how they perceive depression, how the pandemic has affected, you know, mental health issues in seniors, and in general, like what are some of the challenges in diagnosing mental health issues in seniors?
Wow, I thought we were going to space those out, but I'm going to take a stab at doing all that. So yeah, I'm happy to address that. I'm going to talk, when I talk about older adults, I'm talking about patients above the age of 65 and really closer to the age of 80. In geriatrics practice, my average age is 82. So like Marc was saying, when patients have mental illness or when they have depression, it's different for everyone, but there are some clear patterns that are important to recognize because there are areas that you can intervene and really, really help, especially if you're in the right place and you see it. So what do I mean by that? Depression in general has a really interesting relationship to dementia. And there's actually a syndrome called pseudo dementia, where a family, I see this all the time, brings their loved one to see me in the office because they're afraid that that person has Alzheimer's disease. But what they really have is depression that has been going on for a little while. And if you can recognize that and tease out those differences, and that is possible with kind of what you observe and how questions are asked, you can treat the depression and then you will cure this dementia that isn't really a dementia at all. So it's really important to bring that out. Another component that I see a lot in that particular kind of dyad, adding in hearing loss. So undiagnosed hearing loss, it pulls people away from the world. And it can also present like a dementia because you can't remember what you haven't just heard. So that combination, depression, hearing loss, and this presentation of confusion or not thinking straight is common and fixable. So really important. Seniors present really, really differently than younger people do. The complaints that come to an office are not typical kind of, let's say, more emotional complaints. They're more somatic. They're more physical symptom based. And that can be hard to tease out in an older adult population because depression doesn't happen or mental health illnesses don't happen all by themselves. They happen in the context of other chronic medical problems and in the context of other medications and things that people are taking. When Joe mentioned substance abuse, I hadn't really thought to comment on that, but one of the things that we see in older adults, and I say all the time, the older you get, the cheaper a drunk you are, right? Because your body, it doesn't metabolize the things that you take as well as they would otherwise. And you're combining it with other maybe prescription medications that can make that situation harder. So I guess my main point in how depression or mental illness presents differently in older adults, there's a somatic component. What I mean by somatic, physical complaints will outweigh the more emotional complaints. And the memory loss is a red flag. In my office, when I see someone that comes in because their family thinks they have Alzheimer's disease, but I can pick up the signs of depression, even though depression is hard for people to have, I get kind of excited because I know I can do something where I can't do as much if it's an illness that involves a dementia. I will say that the pandemic has been super hard on everyone, but very hard on older adults who are isolated and living alone. So there's two sides to it. Older adults, believe it or not, a lot of times are better at dealing with stress and challenges than younger people are because they have had 80 years to develop their strategy. And some of them are very good at that. That being said, the pandemic is testing everyone's strategies because the things that we do to relieve stress, having dinner with friends, going on vacation, exercising outside, being with groups of people in our synagogues, right? We can't do those things in the same way. And that has magnified, I think, what people see at home. Same thing with anxiety and panic, really magnified by not being able to do these things that have helped people all their lives deal with those symptoms. So if anything, the pandemic is magnifying things. And I think it may also be harder for loved ones to recognize when something's wrong, because they are not with their loved ones as much as they would have been otherwise to see that. A couple of special populations that I'll talk about. Um, Pancreatic cancer, weirdly, sometimes presents with just depression, not to scare anyone, but this is why if you have an acute depression in a place that you wouldn't necessarily expect it, it's important for older adults to get looked at, to have someone look at everything that's going on medically. In older adult men, that population of the men above the age of 85, they are more likely to commit suicide if they're feeling depressed. That is the population most likely to do that and to take that seriously. A lot of people who are depressed, the overwhelming majority, will visit a primary care physician in the weeks before they end their life if they're contemplating suicide. But they won't come and say, this is what I'm thinking about doing. There are other reasons for that visit. So you have to be sharp to see that. I would say that that older adults do recognize depression as a problem. They see it as a medical problem. Most of them will say, I think more than half will say they can handle this on their own, right? And that's the danger zone. I mean, there's so many wonderful programs and community services that can fit that other piece, and no one has to go through this alone. So I think that's something to watch out for. So if you love someone who you think is depressed, I think that the moral of the story is get them some help, right? Have an evaluation. Make sure that it's not other things. People who are older have a lot of chronic medical conditions, and sometimes a symptom related to a chronic medical condition can be treated and really improve someone's quality of life and change what that outcome is. So in geriatrics, we talk a lot about syndromes. It's not just one diagnosis. A syndrome, a geriatric syndrome, is a presentation that has lots of different reasons, not just one, right? So when you look at someone like that, not just the one diagnosis, because believe me, no one who's 80 years old comes to my office with one diagnosis, but you look at all of those other things, you may be able to make a difference. Perhaps they've been on 11 or 12 medications for the last 20 years, half of which they don't need anymore. Could make a very big difference as well. The other, one point I'll make before I stop there, I didn't touch on everything, but close. The point that I'll make is, in my opinion, as a practicing physician, depression is a treatable illness. Anxiety is a treatable illness. Panic is a treatable illness. And the mental health issues that are more significant than that, the ones that involve more symptoms that are closer to psychosis, these are treatable illnesses. And that's why it's so important to get the right kind of help to be able to treat them, because you can really improve them and you can improve quality of life. Did I miss something, Dan, that you wanted to mention?
Nope, you nailed it. Thank you very much. I'm reminding everyone that if you have questions, please put them in the chat. We left plenty of time for that, and I think it's important. So, don't be shy. Please feel free to ask. Bill, so you're here to talk about mental health issues among tweens and teens, something that many of us here as parents and grandparents, and there are some educators here, are concerned with. Can you talk about how we, the adults, can talk to kids and adolescents about mental health, how to deal with extreme cases such as suicide when that becomes an issue, and something that's very, very important to me, because as a parent of a teenager, I'm dealing with this all the time, how social media plays a role in all of this. which for me is a battle on a daily basis with my team. So I'll turn it over to you.
Well, thank you. So since I have the topic of adolescents, teens, mental health, suicide, and social media, I may not get to everything. But the first thing we want to think about is adolescence in general. A lot of people don't realize that adolescence really is a relatively recent concept. And when I say relatively recent, I'm talking about a little over 100 years or so. Because prior to that time, kids went from playing in the yard to working in a factory to working hard labor, doing different things, and not going to school past 4th or 5th grade. So we have the category called adolescence, where these kids are, say, 12 to 18. You all know adolescents who have been much longer, but we don't really know what to do with them. So they don't know what to do with themselves. We don't know what to do with them. We make sure they're in education. Some want to, some don't. But to give you an idea of how we tried to figure this out as a society, in New Jersey, 16 years old is the age of sexual consent, that you can legally give consent. 17, you can get a driver's license. 18, you can vote or enlist. And 21, you can drink. So we really don't know what the heck to do with these kids, right? So what we do know is that adolescents today are the same adolescents that got complained about in Roman times that we can see in writings that are hundreds and hundreds of years ago. They complained about adolescents at the time, and we do the same now. The difference now is twofold. One, they're our kids now. And two, because adolescents today have to know more, they have to do more, they have to absorb more information, and they have more multitasking than any generation in history. The internet has opened up a lot of things, but it hasn't closed anything. Even some things that probably ought to be closed. So when you think of an adolescent particularly, what do we think about adolescents? Well, they have mood swings. Well, they're angry a lot. They don't talk a lot. They keep secrets. They're kind of paranoid about parents, you know. So if we looked at adolescents as a diagnosis, it could fit into our diagnostic category. Hopefully they grow out of it. So how do we talk to them? Well, in many ways, it's very simple. You just talk to them. The difference is when I look at the topic and they say, how do we talk to kids and adolescents? That's not usually what people mean. What they mean is, how do we make them do what we want and how do we make them listen to us? It's not the same thing. It's really talking to them. If you're going to talk to your adolescent or your child or your tween, you've got to be prepared to listen. And that means you got to be prepared to hear things you may not want to hear and may not be prepared to hear. But it's better if you hear them than if you don't hear them. You want to create an atmosphere where anything is a possible topic. And if you don't know the answer, don't make something up. Because there is no group in the world that is more intuitive than adolescents. If you are trying to put something over on an adolescent, they will smoke you out right away. So we've got to figure out how to help them. Well, adolescents don't usually want to be helped, you know, and they will tell you they don't want to be helped. I don't really care. It's not up to them. We're going to help them anyway. So we talk about mental health, whether it's adolescents or anyone else. The first thing we have to understand is, what is mental health? I know that sounds like a simple concept, but I think we're much better at identifying the opposite. What isn't mental health? So there's a book that we use for diagnosis called the DSM-5, the Diagnostic and Statistical Manual. It has all our diagnoses in them. And I will tell you, we are all in there. We all have categories, we all have anxiety, we all have different things, and we all treat them in different ways, sometimes professionally, sometimes other ways. So when you see your child acting strangely, and if you have an adolescent, you will see them acting strangely. It's okay to ask them about it, to talk to them about it. One of the things, one of the other panelists said, I believe, was that you have to notice everything. If you don't notice it, they will have to do something else to make you notice them. You don't have to correct it necessarily. If your son or daughter comes down with a different hairstyle, whether you like it or not, make sure that you tell them you noticed it. Because if you don't, the one tomorrow is going to be a little bit different. If you see some marks on your child's wrist that looks like cuts, and they say it was a cat, and you don't have a cat, then it's probably not the cat. So they will tell you some story about what it is, but it's okay to ask further. You don't have to pressure them. You're not going to lock them into a room and waterboard them until they tell you the truth, but you're going to let them know that you noticed. These are difficult conversations. And what you have to do as a parent or as a concerned adult is take the opportunity when it occurs, because you don't quite know when it's going to be. I was talking to a mother earlier tonight, and her 8-year-old son walked into the room when they were watching Cobra Kai, and it happened to be a scene of 2 women kissing, and he started to ask about it. So she started to talk about it. Take the opportunity when it occurs, because you don't know when it's going to be. Had he not walked in, he probably wouldn't have asked it until another time, but take the opportunity. If you see your child talking about a friend of theirs who has some sort of issue, ask them about it. They may not tell you, but at least they know you want to know, and at least they know you're concerned about it. You don't have to fix it. You just have to listen, and don't try to fix it if you don't know how to fix it. And I don't mean that in a bad way, but a lot of times as parents, we're so concerned about our child's welfare, we want to fix the problem before we actually figure out what it is. And sometimes, frankly, we don't have a problem, or I'm sorry, we don't have a solution. So sometimes what we want to say is, you know, no one's going to remember 10th grade. It'll be okay. You know, when you're an adult, you won't care what happened in 10th grade. The problem is they're in 10th grade, and they've got to deal with it tomorrow. You know, so the only thing, the adolescent, if you have an adolescent clock, the only thing it says is now. That's all they know about. And that's okay, as long as you recognize it. So there's adolescents and teenagers now know more about mental health than we ever did when we were kids. Now, unfortunately, not everything they know is correct, but they know there's a stigma to mental health. Every kid knows that. You know, every kid knows a kid that's picked on in school, there's a reason why. Not a fair reason, not a good reason, but there's always a reason. So we have to help them be the one that helps the other kids. I'm going way over time, but I'm working on it. Okay. So mental health issues, we know, I'm sorry?
You're good, take your time.
Okay. So we know that mental health issues for kids look a little bit different. Okay. We know that they're impulsive. We know that other than the elderly, they have the highest suicide rate. So if you think your child is suicidal, you need to talk to them about it and ask them about it. You will not make someone suicidal by talking about suicide. Because we're talking about suicide tonight, and I really expect none of you to go home and harm yourself. It's a topic as if it's a secret. We don't want it to be a secret. And if it's not something they're concerned about, believe me, they will tell you that as well. But I can guarantee you, if any of you have kids in high school, they know kids who are suicidal. Now, they may not act on it, because we know a lot of kids have suicidal ideation and don't act on it. But if you know, there's one thing in this world that we take away your civil rights based on what you might do. It's not a criminal offense. We take away your civil rights and we put you in a hospital against your will if we think you're going to harm yourself or others. The reason for that is that we know that most all the time, this will pass if we can keep you safe through this time. And it does. You know, it doesn't, listen, if someone really wants to kill themselves, there's very little any of us can do because we won't know about it. But thankfully, most everyone else is ambivalent and we can help them. So it's not a secret. If you're concerned about it, let them know you're concerned. Lastly, about social media. Social media is what I call the newest reason why civilization is going to end. There's been reasons like this forever. It was Ozzy Osbourne, it was Black Sabbath, it was whatever it was in Roman times, I don't know. Now it's social media. The kids growing up today do not know a world without social media. So it's normal to them. So I remember talking to a parent a number of years ago who used to talk about how my kid plays video games. When I was a kid, we were outside. We weren't playing video games. We were outside playing with our friends. Well, yeah, because you didn't have video games. If you had them, you would have been playing them just like they are. So it's okay to limit the time. It's okay to be a parent and sit in the discipline. But for social media, you need to be aware of what is in your child's social media. You are the parent. They're not going to like it, and they're going to find ways to get around it. You know, most people know about Instagram, and they call them Insta accounts. You know, one of the many kids, maybe yours, have what's called a Finsta account, a fake Insta account. So usually that's an account that the parents have the access to, and they have other ones that the friends have access to. It's not necessarily bad, and you're never going to know all of them, but you want to make an atmosphere so that, for example, if your child has a cell phone and they're 15 or 16, it is not really theirs, it is yours. And if you're the one that has to exert the control, the parental controls, as well as, I would suggest for most kids, they should not take a phone or a tablet to bed with them. not because anything awful is going to happen, though it might, but because they need to go to sleep, and it's very distracting, and it's often hard for kids to learn. There's a society now where if you have to turn things off to disconnect. There was a time when some of our older folks like me, remember when they used to have the national anthem, the TV shows would go off the air, the station would go off the air. Nothing goes off the air anymore. So we have to turn it off. They have to turn it off. We have to help them turn it off. There's a whole lot of other stuff we could go into with a big topic, but basically the message for all of it is to have open conversations with your kids. You are not their friend. Do not try to be their friend. You can be friendly, which would be very nice, but until they are asking you what time you have to go to bed, other than them asking you, you're the parent. So make the open conversation, but again, don't be afraid to ask questions. If your child needs a medication or you think they might need medication, make sure they go to a child psychiatrist, because medication is very different with children and adolescents. And if they need medication, think about it like any other medication. But remember, we don't ever ask people with physical illnesses to beat it with willpower. If they need medication, they need medication. So if kids need medication or adults, it's not about willpower with mental illness. It just, I wish it worked that way, but it just doesn't. So I've exceeded my time, but I do that. So I apologize, but thank you.
Not at all. Thank you. And I wish I would have grabbed my daughter and have her sit next to me during this, doing your part, but it's recorded, so I think I might play it back to her. So, so we have about 15 minutes or so. There are some questions in the queue. Rabbi, there's one for you. So the question is, we have spoken about awareness. What do we need to think about in addressing, confronting, caring for family and friends? With all the resources out there, how do we respond internationally?
Internationally, interpersonally, well, I'm not sure internationally, but I'm going to deal with the personal.
Maybe it's a mistype.
But I think that Bill started handling this, but this isn't just about how we talk to our kids. Empathy is a huge piece of this conversation. Being not sympathetic, feeling badly for somebody, and certainly not judging, but feeling concerned with somebody. And so it plays out in all sorts of ways with your kids that, we've got some experience that they don't have. And so we can understand more. And as Jesse said, when you talk to an 80-year-old, they know a whole lot more than we do. And so we can't tell them how to fix things. We have to work with people and be partners in this. And, sometimes we're dealing with treatable illnesses, and sometimes they're not treatable. You have someone with dementia who has just lost a loved one, and you walk into the room and you tell them you just lost a loved one, and they go through trauma. And tomorrow you walk in and they ask for this person, and you say, well, I told you yesterday that person died, and they go through the trauma having heard it for the first time all over again. So there has to be some real discernment and empathy in how we make sure we respond to and with people. And so, Bill, what you'd said about asking questions and listening first is huge, and certainly not just to our kids. And as we're now dealing with aging parents, this becomes an even greater issue because parents don't like to be parented. And my mom is 86, God bless her. And I'm starting to enter that role. My sister and I are parenting mom, and it doesn't go very well when she realizes that she's being parented, because there's a dignity piece to this. And in part, it's the stigma that we as a society have created, but it's also the stigma that someone feels when they know that they're not in a place that they have been. And that's real challenging for us when we love someone to help them in that realization without pushing buttons or without feeding onto their own concerns and anxiety. So, and empathy is not something that we're born with often. It's something that we have to learn, and through caring and conversation. And the key word is listening to people.
Thanks, Mark. So it's almost as if you knew the next question I was going to read, but it has to do with the elderly. So Jessica, I think this might be directed to you. What would be the first step for an elderly person? Would it be a regular physician or what?
So more than 55% of older patients are treated for mental illness in the primary care physician's office. The problem with that is a lot of primary care physicians don't have the time to recognize something that takes both empathy and patience. So I would say if you are the loved one of someone who's older and I would attend the primary care visit with them so that you can focus on some of what you're concerned about. So in my specialty, I'm a geriatrician. So I trained first in internal medicine, and then I did a fellowship in geriatric medicine. And a big part of a fellowship in geriatric medicine is a concentrated time in geriatric psychiatry. So I'm not a psychiatrist, but I have a lot of training in that area. So, and a geriatrician has a lot of time to spend with patients when they see them on initial visits. So that is a great first place to go if there are a lot of things going on at once, to kind of tease out what that might be. And in fact, there are a lot of internists who refer patients to me for just that reason, to help them tease those types of things out. So I think you can start with a regular physician if it's someone that has time and the empathy that Mark talked about, or you can look for specialty care. You don't need a referral to see a geriatrician, and you don't need to give up your doctor to see a geriatrician. It's a consultation, just like cardiology or gastroenterology or whatever other specialty.
Great, thank you. Here's one more. I don't know who exactly it's directed to, so panelists, you might need to volunteer. How do you help a middle-aged person who you know has depression, and they also know they have something, but is afraid to be helped for whatever reason? Is there anything to do, anything we can do? So I don't know who wants to take this one.
Well, I think, again, it's kind of the same thing we were talking about with the adolescents. We're trying to talk to them so they do what we think they should. And I think that we're very good at figuring out what other people should do. We're not so good at figuring out what we should do, but I think talking to them about it, and I think as was mentioned before, I'm concerned, the sentence that Joe was talking about, that, I'm concerned, I see this, and you can't force them to go unless there's some sort of, more serious issue of suicidality or something like that. But it opens up the conversation that might be picked up again a week from then, or might be picked up again a little later. So I think persistence and caring and empathy in that conversation is always the way to go, and just doesn't always happen the first time you talk to them.
Yeah, I agree. It's about seeing people. It's about taking the time to recognize things. I think it was you, Bill, but it might have been Joe that said, when people say, "Well, how do I talk to, my child or about what I see?" And your answer was, just talk to them. I think a lot of starting to head in the right direction is about opening that door.
Right. I think people are looking for the right words, and what we call the right words, the words that give the outcome that we want. And the reality is, we don't know what those words are. So use the words you have.
Yes.
Okay.
I would just, if I could add
yeah,
to
go
that,
ahead, please.
and particularly because we're talking to people of faith, and that is that the thing that is overwhelming for people who experience depression and anxiety is hopelessness.
Right.
And so my good friend Maureen, who wrote the Lifeline Suicide Prevention Curriculum, says, when you meet someone who has no hope, give them some of yours. So when someone is experiencing hopelessness, you can give them hope to understand that things could be better, and that you're willing to journey with them towards that if they want you on that journey. You can't drag them kicking and screaming, but you can offer to journey with them. And if you have a personal story, it doesn't have to be the same story. It's not to trump their story, but just to say, I've experienced challenges in my life, and when I got help and support, I felt better. We know that the overwhelming majority of people who receive appropriate help and support see a significant improvement in the quality of their life.
Yeah.
that this gets better when people get help. And so to offer the journey with someone and to be realistic, just very quickly, if I woke up this morning with a headache, we know what my course of treatment would be, right? I'd take 2 aspirin and 20 minutes from now, I'd feel better. The course of treatment for people who are experiencing mental health challenges, particularly depression and anxiety, isn't as simple as take 2 aspirin and you feel better in 20 minutes. So folks need somebody to journey with them because it can take a long time to get the right medication and the right dosage, and there's suicidality risks, and there people, people feel they don't feel like themselves, and people gain weight, and there's a lot of things that happen with medication as one of the ways that we help people who are experiencing a mental health challenge. So having somebody who says, I'll walk with you through this journey, and I'll encourage you, and I'll pray with you, and I'll listen to you when it's not working, and I'll go to the doctor with you if you want me to. Just knowing that somebody's journeying with me makes the journey a whole lot easier. Whether that's a friend or a peer or a son or a daughter, just having somebody who's willing to join with me. And just to piggyback a little bit on what Bill said earlier, the number one protective factor for a kid, number one, is a trusted adult. And so if you have children and grandchildren and nieces and nephews in your life, whether they're 3 or 13, you need to have a conversation with them about who the trusted adults are in their life. And that starts when they're 3, and you say, if you were in trouble and mommy and daddy weren't around, how would you get help? And revisit that conversation every year until they leave your care. And in my congregation, once or twice a year, I say during the service, I said, if you're an adult here today and any teenager or any kid who's here in this building can call you 24/7, 365 if they need help, please raise your hand. And hands go up all around the room. And I say to the kids, I say, look around the room and see whose hand is up. And during coffee hour, go up to Mrs. Johnson and say, Mrs. Johnson, I see that you raised your hand. Can I please have your phone number and can I give you mine? Put protective factors in people's lives, and especially our young people. Number one protective factor, trusted adult.
And along that lines, Joe, one of the hardest things, maybe the most traumatic time for someone seeking help, are the initial stages of help. It takes a lot of courage to reach out, and after help begins, the worst parts of therapy are the first several sessions when you've got to actually face that there's a problem. And that's all the more when you really need someone you can count on to say, yeah, I'm here. I've got your back. I've got your arm. I'll walk the journey with you.
Because that's when people are more likely to bail out.
Right.
Those first couple painful sessions are when they're going to bail out. And so if somebody is saying, it gets better, I'm here with you, I care, they might go through that first 2 painful months to get to the breakthroughs that will begin the healing process.
Yep.
Wow. A lot of important information here. And I know we're coming up to the hour, but there is one more question, and I think it's important. So, and worth the extra minutes. So regarding, and I'm not sure who wants to answer this, maybe Joe, but you can all decide. So regarding young adults with special needs looking for work, how do we help both as parents, adults, and as employers? How do we help?
I can just talk from the perspective of my own children, some of whom are not capable of because of their significant disability of working, and so finding meaningful engagement for them during the day is a huge issue. And this is not easy. If you have teens getting registered with the appropriate services with DVR and DDD, and those services starting at 15 and 16 years old. So as people age up into the adult population, the services are there. And having a relationship with whoever might be providing opportunities for employment for the young adults or older teens in your family, having a relationship, having a cordial relationship, having open communication, having a safety plan in advance, so that if that young person becomes overwhelmed, needs additional resources, that's not a panicked call. That's a call that you already have plans in place for. But I think DVR, the Department of Vocational Rehab, and DDD, Division of Developmental Disabilities, have those resources in place. And those are the folks really who have more expertise in that regard. When there is a mental health component, and we know that developmental disabilities, often 50 or 60% of people with a developmental disability have a co-occurring mental illness. And so the challenge is when you have both of those, we know that CP is a significant issue in the Jewish community. And so you have that co-occurring, perhaps with a depression or an anxiety disorder or an autism spectrum disorder. So bringing those two pieces together is hugely challenging because they're funded from different silos, they're approached from different points of view. And so it can be really challenging. And so that parent advocacy role is vital, and having other parents who can support you is a big help in that journey.
Thanks, Joe. Okay, so we're at the hour, so I think we'll wrap up. If any of you have any further questions, you can always email me and I'll be happy to pass questions along to our panelists. I want to thank each and every one of you, members of the panel, for being here, for helping me plan this, everything, really. This was extremely informative and important. And I'm really impressed listening to all of you. So thank you, thank you. Those of you in the audience, I will be sending out a survey which will not just let me know what you thought about this program, but what you might be looking for in the future. We're exploring ideas. One of them is to work with Joe, maybe to put together a mental health first aid. It was a course or seminar. I don't remember exactly how you phrased it, but so we're looking into that and we'll be asking that also on the survey. So please let us know. And that's it. So thank you very, very much. Have a great evening. Don't drive anywhere. It's all icy out. And good night. Good night to all.
Good night, everybody. Thank you so
Good
much for the
night.
opportunity.
Thank you, everybody.
Thank you. Nice meeting you all.